I think we're going to get started. My name is David Edelstein. I'd like to welcome all of you to the fourth Alan and Sybil Edelstein Lecture on Professionalism and Ethics in Medicine. Tonight's topic is the ethics of end-of-life care. Next slide. I'd like to introduce our wonderful Dr. Hee-Young Park, our Dean ad interim of the Chobanian and Avedisian School of Medicine. I noticed that you're the Caroline Nigerian Professor and Chair of Medical Science and Education. Carol Ann is actually a beloved member of my class, so I'm really happy that she funded your chair. She's also Professor of Dermatology and Associate Dean of Faculty Affairs. Dr. Park.
Thank you so much. Welcome, everyone, and to the fifth lectureship. And I'm very pleased to actually introduce our moderator. Next slide, please. Dr. David Edelstein, who was former chair of ENT at Northwell Manhattan Eye, Ear, and Throat Hospital. And also he received the Distinguished Hospital Attending Distinguished MD Award. He is also clinical professor of Weill Cornell Medical College and past chair of Board of Governors of American Academy of Otolaryngology, HNS, and he also received AAOHNS Distinguished Service Award. He's our proud graduate of Chobanian and Avedisian School of Medicine, as well as Dean Advisory Board member, and he received a Distinguished Alumni Award from our school. And he's also Helen Keller Manhattan League and received a Distinguished Service Award. So Dr. Edelstein, thank you so much for moderating and sponsoring this really valuable lectureship. Back to you.
Thank you, Dr. Park, for those kind words. Next slide. I'd like to acknowledge support from my sister, Marcia Edelstein Herman, the med class of 1978, who's been involved in this lectureship since the beginning. Dr. Greg Grillone, who's the Strong and Vaughan Professor and Chair of the Department of Otolaryngology, under whose auspices this lectureship occurs. Thank you, Greg. I've known you since you were a med student. And again, Dr. Sam Lowe, who's Assistant Professor and Director of Chaplaincy at Boston Medical Center, who has helped me all along the way the last year in coming up with this program. And we have our panelists. Next slide. I am going to just mention that this is in memory of my parents, Alan and Sybil, that many of you knew. My dad was management class of 47 and law class of 49. My mother, although went to another college, was a happy member of the extended BU family, and her father was the law class of 1921. My dad, after Marcia and I graduated, was appointed to the Dean's Advisory Board, and they were the founding members of the Parents Committee, which I found very valuable, and I think the students did also. And I'll just say, during my entire career, I would come back to them and ask them questions on challenging issues. And it was a dynamic duo. My dad would say, "Is that the most professional answer you have, David?" And my mother would then ask, "Is it ethical?" Next slide. We've had 3 previous lectures on professionalism and patient trust, one on the ethical challenge of the COVID crisis. The next was last year on the genetic testing ethical dilemmas, and then this year. And hopefully many of you will send me some ideas for future programs. These are all also on YouTube, and I encourage you to go back and listen to them. Next slide. Please mute your microphone. In the chat function, if you have questions, there'll be time at the end to answer some of them. And again, this will be recorded. Next slide. So, the public, is wrestling with this. You can see where the New York Times has had a variety of articles. Let's talk about death. Most people don't want to talk about it. And, I'm dying of cancer. Do I have to tell anybody? These are really very heartfelt questions. In the Wall Street Journal, how do you make your wishes for end-of-life care clear? And we'll see in many of the speakers how we can all do that and help our parents or others do that. More people are dying at home. Is that a good thing? And one of the hot subjects, as we see in the Atlantic, is Canada is killing itself, assisted suicide. Now, one of the speakers may allude to it. We're not going to really chat about that too much. That's the whole subject of another lectureship in a year or two. Next slide. There are a variety of universal principles as you're listening to us tonight. The first is autonomy, that the patient always has the right to self-determination. This is what advanced directives mean. And you'll see that most of our advanced directives are probably not specific enough. People think that DNR is the only order you can have. We'll chat about that maybe at the end. There are a whole variety of different orders that you can include in your advanced directive. Beneficence, if there's no advanced directives, what do doctors do? And that's pretty obvious. They advocate for the best care available. Non-malfeasance, primum non nocere, first do no harm. Not so easy to do sometimes when things are happening quickly with your patient. And again, justice. And I'd like to think that we at BU, that this is a big deal since I trained at Boston City, which is now Boston Medical Center. We're providing a fair distribution of healthcare with some impartiality is very key, particularly in our society today. Next slide. But as much as you think that you're prepared, I'm just going to make a brief comment. You're never really prepared, and what one death may help you understand may not help you with the next. And I don't mind mentioning some of this. Alan, who had his first heart attack at 50, passed away at 92. And he'd been in the hospital 6 times in the last 2 years. And he told Marcia and me and my mother, Sybil, they did not want to go back to the hospital. And so when he needed to, near the end, we acceded to his wishes. And one day he just didn't wake up. But that's the autonomy. He gets to make his own decisions. And for those that knew him, he was definitely opinionated. Sybil, the issue is not to do any harm. She had a very elaborate DNR order. She became septic and arrested. And the question was, what part of the DNR order to do? And the answer is no, resuscitate her. That was her wishes, that if she could survive, to do it. I'll just say 4 hours later, when she arrested a second time, the question was what to do. They said she's still viable. But the third time when she arrested, the issue was that would not accede to her wishes and did not hurt her anymore. Joseph's my father-in-law, and he had Alzheimer's, and at the end was sick, and the hospital he was at wanted to deny him food, water, and an IV, which I was diametrically against. He had some advanced directives, but not completely, and so the family met several times. And I know my wife went to visit our rabbi, our chaplain, who will hear our chaplain, and that our opinion was correct, that only the Almighty can take away food and water. And he passed away a few days later with some comfort. And my best man, who had 20 months with a small bowel cancer, who died recently and was treated at Memorial very well, but had a disease he could not survive. And although I was honored to be, quote, part of their extended family, the question is, whose ethics is it? And how do you, with different cultural backgrounds, make those decisions? Next slide. So our first speaker is Alan Carver, who was Chobanian Avedisian, class of 1995. And he's dual boarded in neurology and hospice and palliative care. He's co-editor of one of the clinics on this subject of North America. I saw that you were associate dean at Mount Sinai, and hopefully we're trying to bring in med students and young doctors who would not only be intelligent, but also sympathetic to some of these issues. And now I'm going to hand it over to Alan. Alan.
Thank you, David, very much. And thank you for this most wonderful and generous invitation. It's an honor to join all of you this evening to talk about some very important issues, and especially that this is related to my BU family of origin, just makes it that much more special and meaningful. So thank you very much. My email is there for all of you to have. You're most welcome to contact me that way if you like. I've spent most of my career as an attending neurologist and palliative care physician at MSK, Memorial Sloan Kettering Cancer Center. And I have an academic appointment at Cornell and do a fair amount of teaching there in the med school. What I'd like to talk with you tonight is, in the 10 or 12 minutes that I have with you, is about what I would call an ethical imperative, and that is the right to excellence at end of life. And I do mean right, and we'll get to that in just a moment. Next slide, thanks. So just to know that we're all on the same page, we continue to face this. We continue to find that we need to define and redefine just what we mean when we talk about palliative care. I like the World Health Organization's definition, among others, but I share this with you: the active total care of patients whose disease is not responsive to curative treatment. And the WHO, I think, in their wisdom, emphasized that this is an active process, right? I knew I was in trouble when I came here actually as an intern, as part of my training in neurology. I trained part of the neurology residency at Cornell. I spent at Sloan Kettering, which is how I sort of got here, and in some ways never left. And I had an attending physician at the time who came out of the room with this young man who was not expected to leave the hospital. And he looked at all of us very dour, and he said, well, I think it's there's really nothing to do. I think it's time for palliative care. And there was this sort of equation between nothing to do and palliative care. And then as I began to learn more in my residency and fellowship, I began to understand the following kind of take-home points that I want to share with you. One is that palliative care is in no way is it equal to hospice care. Hospice care is just one facet of palliative care. In the 1,100 page or so textbook of Oxford palliative medicine that I have in my office, there's a chapter on hospice care. Sure, of course there is. But that's one chapter out of 1,100 pages, right? Palliative care may be appropriate from the day of diagnosis or soon thereafter. It's never about stopping care or withdrawing care. It's all about living. It's about living with incurable illness as well as possible for, as we like to say around here, as long as possible. It really is about life. This should not be an evening or a focus about death. There should be a focus about how we help our patients to live, if you will, as well as they can for as long as they can. Okay, next. So when I graduated from BU, I didn't appreciate this at the time, but in JAMA, there was a study that came out that showed it was an indictment. It's really what it was. Honestly, it was an indictment of all of us. And what it found essentially is that we in medicine were doing a terrible job in caring for our patients at or near end of life. And what's remarkable is that 1995 was also one of Dr. Kevorkian's peak years. So at the same time that we were beginning to amass a lot of very compelling data that showed that we really didn't know what we were doing and didn't know how to care for our patients at or near the end of life, we had these physicians and even a Supreme Court that was grappling with, so what do we do? Dr. Kevorkian had one solution, and I began to realize in my training and in my young career that there were, in fact, other ways to care for patients who were dying other than ending their lives. Next. So jump forward a little bit. In Boston, at what was Brigham and Women's at the time, one wonderful researcher named Jennifer Temmel. Some of you may know her work, And this caught national attention, as you see, and national headlines and news headlines, TV news headlines, because it was one of the early studies to show that, in fact, if you care for patients well, even those who are expected to not make it, to die, they will nonetheless live longer. And one of the ways that we find we can, if you will, sell the notion of good palliative care to patients with cancer here, and metastatic cancer, limited life prognosis, is by helping them to understand that caring for the patient is so much more than the chemo, the radiation, the surgery. It's about the person. And when we begin to care for the person and the symptoms, we begin to realize that, in fact, people will live not only better, which is sort of stands to reason, but they'll actually live longer. And that's why I share this with you, because it was a remarkable study. Okay, next. So some of our challenges as we care for very sick patients with limited life prognosis, right? Some patients and families, we see this, they equate DNR, do not resuscitate, or, stopping life-prolonging treatment with withdrawal of care, right? We have families who have said to us, we're not going to sign that order, doctor. And when you find out why, they say, because then the care isn't as good. If my loved one is still getting chemo or radiation, I know the doctors are going to come in and see them every day. If I sign that order, then the team is going to round on my husband at the end. And basically, it's going to be second-rate care. Care of the dying becomes second-rate, right? Some report that a shift occurs from the treatment of disease to caring for the person. You probably see this in your hospital. We certainly see it here. We had a patient recently who's our inpatient neurology team. They placed that patient on what we call here comfort care. And the wife of the patient asked me on rounds, so Dr. Carver, now that my husband is dying, someone's going to ask him how he feels? She was angry. And what she was angry about is that while he had been diagnosed with a brain tumor 2 years before, and in all the time she said that he came for treatment and so on and so forth, nobody asked how he feels. Now he's not getting chemo anymore. People are talking about hospice. She understands that he's not going to make it, and all of a sudden, people are asking, "So how are you feeling today, sir?" And it was very interesting to hear her and to hear her anger. That for her, there were two kinds of care. If you're getting chemo, that's sort of tier 1, and if you're dying, it's tier 2. And she was angry, and really rightly so. So 2 problematic messages, in this interaction, right? One is that we withdraw care. That's the message, is that somehow care is coming away when cure isn't possible. That's a problem. And then the other one is equally a problem, which is that we only care for the person when death is near. Oh boy, is that really true? Because if that's really true, we got a lot of work to do. Okay, next. So 3 goals that I sort of challenge you all with and to think about. One is we need to raise the bar. Patients and families have to expect excellence in palliative medicine, right? People should be coming to places like Sloan Kettering and perhaps Boston Medical Center too, not just because we have the drugs to help to eradicate disease, we hope, but to actually care for the person, right? We need to redefine what it means to be competent. And in our field, in neurology, that has got to include, we believe, basic knowledge of pain and palliative medicine, and that palliative care is a basic human right at all stages of illness. It is not about death and dying. It's about life and living. Okay, next. I am sure that by your elevators and posted around because it's a JACO requirement, what patients in the hospital have a right to. It's always bothered me that, they have a right to privacy, right? But they don't necessarily have a right to aggressive palliative care, right? We know they have a right to refuse treatment. We know they can refuse nutrition and hydration. We know, right, they can refuse resuscitation. But do they have a right to pain relief? Do they have a right to choose their place of death? Do people have a right to what we would call aggressive, which really just means excellent palliative care? Is that the standard? I would suggest to you that our data suggests that it's not the standard, but it's where we need to go. And I would further suggest to you, speaking of Canada, while we don't have time to talk yet about physician-assisted suicide, much of the interest, even the groundswell of support for these issues, comes in this vacuum, right? If someone's dying and the doctor or nurse hasn't been trained in excellent end-of-life care, then sure, suddenly cyanide becomes more attractive. Okay, next, we're there. Okay. So thank you for your time. And I don't want to take up any more of anybody else's time, but I'm very grateful to have a chance to share these thoughts with you today.
Thank you, Alan. And I know there'll be some questions driven by your conversation. Our next speaker is Brandon Oddo, who's a medical student who's taken a small leave to go to Duke Divinity School to get a Master's of Theology. He was co-founder of Grace at the med school, which is grieving, reflecting, and cultivating empathy. He's won a variety of awards, and I think you're going to see his perspective on how he would like us all to be trained to be better med students, better doctors, better residents. Brandon.
Thank you very much. So today I'll be talking about my moral formation around death. Next slide. There's plenty that's disturbing about death. The word disturbed comes from a root word meaning muddy, much like the word turbid that we are familiar with in medicine. Next. It can also mean a sense of bewilderment, to be sorely lured into the wild. In this posture of being disturbed, then, there is a respect for confusion and the impression that one is in a world that can't fully be domesticated. Next. Today, I plan to present the ways I've been disturbed, not to indulge in a sort of gloominess, but to suggest that there's something worthwhile towards one's moral formation as a clinician in providing a capaciousness towards death and in giving space to being disturbed. I'll start with the vignette. Next slide. We were in a hurry to get to the M&M conference that morning. Biopsy. She was in a hurry to catch the breath that was knocked out of her. Positive. Trapped in a gasp that no one else on the team seemed to hear except the other student and me. Pancreatic cancer. The team made way out, leaving only the implication that they might return. I knelt at her bedside. The other student stood right beside. The very little I said in those 5 minutes I've since forgotten. I do remember how her gasp was shattered by a cry, visceral and spiritual. It was one of the sounds of cancer. We stayed, briefly but presently. Once outside of the room, the other student asked me, "Where did you learn to do that?" I wondered if it was a question partially mistaken. The remainder of the morning, we were lost to the rest of the rounding team. Next slide. Though there is growing attention to end-of-life care in our current milieu, medical students feel unprepared to encounter dying patients. In one study, over 3/4 of new interns reported that while they conceptually knew their patients would die, they did not feel an awareness of the reality of death. This gap may be in part because of a hidden curriculum that implies death is medical failure, but I find that the growing respect for hospice and palliative medicine is challenging that. In fact, this is already a burgeoning area of focus in medical education. I'm drawn, however, to the aspects of experience around death that cannot be distilled into a didactic. Next slide. The question, where did you learn to do that, reveals two things to me. The first is the lack of preparedness that we've discussed. The second is that we may have certain assumptions about death, namely that a response to death is entirely something one can learn, as though it were a skill or a craft. I'm not dismissing practice, especially someone planning to work in an end-of-life setting, but I am hoping to challenge the notion that learning to do a response to a dying patient could ever be sufficient on its own. About a year prior to this story, I witnessed my first death while shadowing one of the Boston Medical Center chaplains. Next slide. Beating a beatless heart. 3 daughters crying to the rhythm of futile compressions. The wife is on her way, just an hour away. 50 is too young to expect, to say nothing of what to accept. A dirty shoe dropped, a blade of grass lodged in the tread. Just keep trying. Even if you think his heart stopped beating, we won't stop beating until mom gets here. We keep him alive, even if he's died, until she says goodbye. Even if we cry to the splintering sound of bones made unwhole. Each clinician an interval of palms upon him before cycling out, the chaplain standing, hand on a daughter's shoulder. The wife arrives and clears the room. One imagines her at the side of the bed of the one at her side no more. I tell the chaplain it's the first death I'd seen. He names it a baptism by fire. Now we can certainly take a story like this and categorize it into digestible components. Quite often, this is how the 4 principles of bioethics might be employed, where we'd say of autonomy, what would the patient have wanted? Of beneficence and non-maleficence, when did the chest compressions give way from life-saving to body-breaking? Of justice, would a clinician's time be better distributed to other patients in the frenetic and demanding ED? And these are all essential and significant questions to ask. Yet the temptation is to mistake categories for clarity and clarity for having done the ethical work. Pragmatic as the urge to categorize can be, I'm wary of how it threatens to undermine an awareness of the unwieldiness of the end of life. Next slide. One author of the 4 principles, Tom Beecham, stated that proficient use of principles requires judgment, which depends on personal characteristics. He went on to say, the person who simply follows rules and possesses no special moral character may not be morally reliable. I would go further to say that yes, there are times when categories provide useful clarity for making a clinical decision, yet there are also times when categories can obscure uncertainty. I think a humbled, even reverent recognition of the messiness of the end of life in its totality is crucial to developing moral character and to informing proper responses in this setting. Not just what to do, but how to be. The principles are but ethical tools. What matters then is the type of clinician using these tools. I turn back to the moral formation of a medical student. As varied as medical student reflections are on their first clinical deaths, what remains largely consistent is an intensity of experience that they report. Then, in seeking to normalize their experiences, students report turning to peers rather than to superiors who have grown accustomed to death. Here I see a paradox of normalization. Students wanting to feel normal and being intensely disturbed about death seek out similarly disturbed peers. Yet if a student grows too accustomed to death, they can come to lack the disturbance that allowed them to relate. One can become too normalized to death to be able to normalize being disturbed by it. Next slide. The chaplain in this story named my experience a baptism by fire, a phrase that is compelling and mysterious within the narrative of our shared moral tradition. And after witnessing this death, he and I spoke for an hour. We didn't make tidy of the story, but he permitted me to be disturbed. And what I saw in him was someone who was similarly disturbed, yet had come to find a way to be among and around the death which disturbed him. Next slide. He said he was ready to go home. 3 children in the room and 1 on the phone. He told them to be ready to let go. Very little left to do. Tell the grandchildren soon. They told me to follow him. We weren't doing much medically for him, not anymore, but I should still follow him. He's my patient. He's dying and waiting, and I'm following him. I stayed after the family meeting. He was in a blizzard 30 years ago, and that's what he felt like remembering that afternoon. The next morning, I had very little to present on rounds. The team didn't mind. There's little to say of someone losing their time. The residents smiled and said, "It's good that you're following him." A month later, on another rotation, another death, and another resident told me, "This death was too much. You should go home." Next slide. In some situations, a student may be kept from a dying patient because there is little to learn of treatment with someone for whom little is being done. In others, a clinician may be inclined to protect a student from death, as seen in the latter of these two stories. Now, surely one must discern when to take space from death, but not when this is at the expense of learning to make space for death. Doctors Eberly and Frush explore an application of the do no harm injunction to medical training. They distinguish that which is hard from that which is harmful. That is, there are hard situations that must be endured for a student's clinical formation, and there are harmful instances that must be reformed for a student's flourishing. Yet they describe also a type of harm that cannot be eradicated, a harm that they write is unavoidable in the way that suffering itself is unavoidable in the life of any human being. Next slide. I have found the three of these, the hard, the reformable harm, and the unavoidable harm, entangled in each of my encounters around death. At times, parsing out the three has been helpful. At other times, though, I found a profundity in leaving an encounter in all its confusion and existential weight, in leaving it intact. I return to that word, disturbed. Another meaning of the root word for disturbed is crowded, a sense that everything is pressing in. Or we could imagine that if it's crowded, then one is not alone. Then we are disturbed among each other, and we can look to find the people who can stand right beside us as we behold a dying person, or who can permit death to be disturbing, or who can tell us it's good that you're following him. And together, we can come to see death not only as a reality to confront, but as one to be capacious towards. We can make space for death in all that it brings, the good, the messy, the beautiful, senseless, peaceful, horrific, and the quiet. I'll close with a story of my own experience with death this last August. Next slide. It was dark inside, and I thought, I'm ready to go if this is. It was dark inside, and I was in too much pain to think to ask for any relief. It was a holiday. It was our anniversary. My wife was on a chair in a hospital room in a foreign country, somewhere out there, somewhere far from the bed I was on, just a few feet away. Intussusception with a pH of 7. There was no fascination on this side of the case. Ketoacidosis and lost in translation. Do you have any history of type 1 diabetes? Google Translate on a bright screen, but it was dark inside, and I was fading upon something like a haze. It was excruciating pain, and I thought It was agony, and it was peace, and they couldn't compete. And it was formless and void, undone, uncreated, undomesticated, and then it was just a memory, just a story, just a brief disturbance. Next slide. Thank you.
Nick, next slide. I think there's a bibliography for people. Thank you, Brandon. I'm looking forward to when you return back to the med school and you'll be able to teach us some more. Our next speaker is Professor Dr. Shelly Rambo. You can see her background at the Princeton Theological Seminary, Yale, Emory, and she's a professor of theology at BU. She's been the former interim dean of the School of Theology. You can see her background, and she helps train the chaplains that are going to be helping us with our families on the ethics of end of life. Dr. Rambo.
Thank you so much. It's just rich to hear from Alan and Brandon, so thank you. I'm interested in spiritual care at the end of life and the role that chaplains play in that. Not simply the advising, but the accompaniment and the meaning they make of these experiences. Chaplains rarely get asked or interviewed about their death work, but I think it's an important element of conversations about ethics at the end of life, because we know that chaplains are often there in those moments. I'm a theologian located across BU at the Charles River campus. I educate and research spiritual care professionals who accompany patients, families, and medical staff in end-of-life decision-making. In those moments, religion and spirituality may come explicitly into play, but it's often the case that a fainter or even messier version of belief enters in. A key moment in my commitment to educating chaplains was my own experience of encountering a problematic chaplain who entered the hospital room when my mother was in her final hours of decline. I didn't know it was the end of her life, and like many family members, I wasn't aware of how quickly things could go down, and things went down quickly. I asked that chaplain to leave the room. He was unhelpful. So perhaps in my work, I've been seeking, as a theologian, I've been seeking the chaplain I wished I had. Next slide. Since 2019, I've been partnering with what I call chaplaincy stakeholders, educators, CPE educators, theological educators, endorsers, chaplaincy employers, to think about how to train chaplains more effectively. And you can see images of the folks who are part of our gatherings, about 40 or 50 scholars and practitioners. And at the center, you can see the book that we produced together. Since 2019, and I'm curious about how chaplains accompany people in dying. And they do so at the edges of their own religious traditions and in institutional spaces that speak a different language, the language of medicine. Next slide. In Paging God, are the slides being shown? Can you see them? Okay, I just can't see them. That's okay, I'm trusting Nick. In Paging God, Wendy Cadge writes about the death work that chaplains do within the hospitals, describing the work as counter to the dominant postures towards death by medical professionals. I included a quote there. In hospitals, death is viewed as failure. And the quote, research describes how hospitals and hospital staff respond to death by avoiding it, distancing themselves from it, focusing on its technical aspects and managing it. Next slide. Cadge points out that the chaplains view this death work as sacred, bringing different frameworks and meanings to death that are non-medicalized. So there's a list of chaplaincy tasks related to death that Cadge outlines. Chaplains frame death as sacred work because they're informed by their religious or spiritual frameworks. But the frameworks of their traditions also change when they come into the hospital setting. And this is really my research interest, is how those frameworks adapt and change and become something actually different than the tradition-specific meaning making that they may have been trained for within the theological schools or rabbinical schools. I conducted a set of interviews. This was a couple years ago, and I wanted to capture something about how chaplains are to learn something about how they make meaning in such moments. I asked a range of questions, and not all of them had to do with end-of-life scenarios, but I want to give you a glimpse of what I learned. Next slide. One example, a chaplain who worked for 2 decades in a large New York healthcare system shared this with me. She tells me about visiting Angela, a patient whose health had declined rapidly. Angela spoke with Chaplain Gold about carrying a sense of guilt for mismanaging her own health, for living her life recklessly. Questions that she asked the chaplain was, did I bring about my own suffering? Do I deserve to be in this situation? A few days later, Angela goes into cardiac arrest. And the chaplain describes it to me as big suffering because there were so many people involved, doctors, nurses, residents. The woman's husband was in the hallway screaming hysterically and calling out for his wife. Chaplain Gold stands beside him the whole time. It lasted for 3 hours. She likens it to a hurricane. The staff were rattled, medical residents, all 50 of us, everyone in this storm. Her role, she said, was to hold the space. A chaplain often uses that phrase to explain the work that they do. Her work was to be the calm in the storm. And I asked her how she does that. Oh, wow, I hadn't thought about it, but it's Shabbat. It's a time in the Jewish tradition set aside from activity. Shabbat speaks of a being versus a doing. That practice develops a quality of presence that is essential to this chaplain's work. It's a way of being present that focuses attention. The practices of her tradition taught her to move into the eye of the storm and remain still. This scene was different than others, orchestrated movements in the chaos of the situation. And this is a quote from her, but this crew of people for 3 hours was held in some sort of a bundling, like a swaddling, like you do with a baby. And then when it was over, the husband was in the room weeping and the staff was outside and inside the room, everyone weeping. The staff have to move quickly to the next thing, the chaplain tells me. They're trained to do that. But the chaplain worries about this, about the residue of these scenes on the medical staff. There is always, she tells me, something unfinished about these moments, something unprocessed about the work. From the perspective of the theological school, the chaplain is trained to think communally. We train people to think in big stories and big scenes, and to think of life and death as big themes of existence to which religions attribute meaning and purpose. Researchers like me are interested in the ways in which they tell us something about how religion operates in public, how chaplains do, how religion operates in public outside of tradition-specific structures such as mosques, synagogues, and churches. We're interested in the ways in which they offer something unique to interdisciplinary teams of care. And as I was working through the literature that Dr. Edelstein gave us, I was also reminded of the ways in which chaplains are attuned to the injustice and inequities that often occur in these moments when things go down quickly. Next slide. A healthcare chaplain was called in to advise the ethics committee on an incident involving a mother. The woman, hearing her daughter was dying, had flown in from West Africa and was suddenly in a medical scenario in which her daughter's prospects of living were slim. The treatment was explained to this mother quickly, and she was not complying with the directives, which created an incident ending in a security call. The hospital, the chaplain tells me, has all sorts of codes. but there's a specific one for behavioral or non-medical issues. This chaplain was asked to meet with the mother. The committee wanted to know, was the mother's behavior related to her being Muslim? Is there something about her religion that prompts her to act in this way? And after the meeting, the chaplain reports back to the committee, no, it's not religion. It's a grieving mother. The chaplain shares with me that this security call and others like it really impact her. She tells me that 80% of behavioral security calls involve cultural minorities. These security calls are reminders that culture, religion, and ethnicity register suspiciously within the hospital system. It's a reminder that she, as an employee, a Black Muslim woman chaplain, is also viewed suspiciously. You know, Shelly, she tells me as her tone shifts, I feel these security calls in my body. If we think of the relational scenarios around death in which chaplains are involved, this awareness for this chaplain is something that wears on her spirit, that makes her life more difficult. This wear and tear on the spirit is something she's attuned to, the impact on medical staff of color, medical professionals of minoritized religious traditions. Next slide. The end-of-life literatures rarely include references to chaplains, even though chaplains are frequently present in these moments of death. How, if at all, do they figure into these ethical principles that guide medical professionals? These two scenes, I hope, broaden the scope of end-of-life ethics in thinking about maybe an ecosystem of end-of-life care. When we consider the ways that religious and spiritual traditions approach questions of suffering and death, non-medicalized, such traditions do not have as their main goal the prevention or alleviation of suffering. That, I think, is the medical goal. This seems so simple to say. Certainly, religions do not promote suffering, but alleviation of it is not the singular goal. Instead, the religious or spiritual goal is to dignify human experience and to make sacred the ordinary and the everyday. It is this amended aim that can widen, I think, the scope of end-of-life care to think about spiritual accompaniment alongside principles that guide end-of-life decision-making. Not the prevention of death at all costs, but I think opening up different postures to an end-of-life process. Thank you.
Next slide. Anyway, thank you, Professor. I think you've highlighted, I know here in New York, about 185 different cultural, ethnic, and religious backgrounds for our patients. And the question always is, you know, I can tell them what the patient needs to operate on. I can give them some idea of options, but how do they make decisions? And it's the chaplain frequently that we'll turn to, which is what are we missing in this person's life that we need to entertain. Our last speaker for the moment is Beth Rooney Suereth. You'll see why she's our kind of our cleanup hitter. You can see her background here. She's got a very diverse background. She had an English major from BU, but other than that, she's trained herself on some of these issues. She does have a small conflict of interest, and she's the founder of Caregiving Pathways, but you'll see why I chose her as our last speaker. Beth?
Thank you very much, David. I'm very happy to be here today. I started Caregiving Pathways because of my experience with my dad and as a family caregiver for 5 years. So at one point, it came to the end of life, and it was who decides what happens at the end of life. And so my dilemma was that my dad was 86. He had, next slide. My dad was 86. He had dementia and a new cancer diagnosis, and his physician recommended 2 surgeries to prevent what the doctor called a gruesome death. And so we had a dilemma as a family. We knew my father's wishes. We were all in agreement about what should happen, but we had no framework for thinking about it. We had no education, no awareness of the shift from curative care to comfort care as a concept. And so in our crisis mode of our inability to think clearly because we were responsible for this life and death decision, we're looking at two stark choices. I would go against my gut and have the surgeries, and I anticipated that my dad wouldn't make it through one, much less two of the surgeries, and that he would die exactly the death that he very much dreaded in the hospital in the middle of a medical emergency, essentially. Or to go up against the medical industrial complex and reject the recommended surgeries. But did I even have the guts to do that? And after talking with his physician, I feared his reprisal if I went against what he was recommending. And I was also afraid of legal issues because I stood to gain financially from my father's death. And again, I couldn't think clearly because we were in such crisis. Next slide. So eventually, a friend suggested that we consult an oncologist because my dad's new cancer diagnosis that left him with only a few months to live. And we should have known better. We're something of a medical family. We should have known to say, oh, of course, we're going to go consult an oncologist. So we went and we explained the situation. And he said, I'm going to have you take your dad home on hospice and they'll be there tonight. And they were. And so the next day, I told my dad what had happened and that he had this diagnosis and a short time left to live. And by the third time I told him, because he couldn't remember it, I said, I'm never doing that again. So we put our heads together and decided what we were going to do with the rest of the time that my dad had left. And we're very practical minded people in my family. So we decided to make the best of it, make the most of the time that my dad had left. And we all had a great time. We had a huge neighborhood party that my dad could remember for weeks beforehand and weeks afterward, even though he couldn't remember that he had been married to my mother for 50 years. And we had a series of parties for our family. So we had a few people come for a few days, and then we gave him a bit of a rest. A few more people come for a few more days and had a bit of a rest. And it went on like that. And my dad thought life was grand. He felt good until a week before he died. And we actually had such a meaningful time with him that it was a very different view from what I think most of us imagine near the end of life. So I like to promote the joy that can be found and different perspectives on how to look at all of this. So from the perspective, there is this terrible lack of awareness of the healthcare system, hospital culture. So people are dealing with a situation where they're not familiar with how it works, why it works that way. Again, very little knowledge in the general public about the shift from curative care to comfort care. Most people have never heard of a pulsed physician order for life-sustaining treatment and how it's so much more specific than any other advanced directive, and how helpful that can be to EMS, to your primary care physician, especially at the end of life in a medical emergency. Most people I have not even sat down to think about what their own wishes are for end of life care. And for family caregivers, it's a very difficult topic to broach with the person you're caring for because it sounds like you're trying to hasten somebody's death. That's often how it's perceived. There are also problems where other family members' wishes don't align, and that can cause a lot of rifts beforehand. But I'll tell you, it causes a lot more rifts after the fact when they're dealt with in a crisis rather than before a crisis. And there needs to be an awareness and discussion on all parts of the family and otherwise about who has, for somebody like my dad, what's the priority order for who has the say in the situation. A lot of times it's the loudest person, but is it the spouse, the children, siblings, in-laws? Who gets a say, who doesn't get a say, and whose say wins out at the end? There are also a lot of considerations, such as the financial cost to the patient and the family, and the payer, the insurance company, and the hospital. And when we are looking at the end of life care, and there are the people who say, I want that person to live forever, as long as humanly possible, no matter what. But then I see families who have bills at the end, and they see the suffering that somebody endured for care that wasn't effective and didn't gain any time, really, certainly didn't gain any quality of life, and they second guess themselves. A lot of what drives people's approach to any and understanding of any of the end of life care is fear. And fear is something that we don't address in ourselves. We don't address from a healthcare perspective. But what I see is a lot of situations where fear is actually the driving factor. Fear of pain at the end of life, fear of having to deal with complex emotions at the end of life. And so making people aware of the fear and how it affects their decision making goes a long way to helping prevent regret when looking back at this experience. Because from what I can see, there are basically two ways of existing through this experience. You can plan and prepare or react and regret. And those are the two things that I see. So I'm here to encourage people to plan and prepare. Next slide. Another perspective is the physician's perspective. And systemically, there is a lack of time because of performance and documentation pressures for physicians to talk to families and prepare them for what's coming. There's a lack of education, as we've discussed today, where the focus is fixing people, and rightly so, but then there is a transition period from that curative to comfort care that is not emphasized. Quality of life, I love to see a physician describe each option for end-of-life care, and then what the quality of life after each decision can be expected to be. Because what we understand generally is what we see on TV, that somebody goes into the hospital, has this emergency care, they're eventually back home just like they were. And that's just not how it exists. Everyone has at least a little bit of a decline, some people a huge decline, and some people will actually reach the end of life. We don't discuss the option of a natural death. Had anyone said to me when my dad was near the end of his life, if that physician had said, here are the surgeries that are available, and basically the other option is to allow natural death and keep your dad comfortable until the end, that would have been a completely different experience for me. And it would have made it so that I didn't have the 4 worst days of my life trying to figure out how to manage this situation. It also gives people advance notice that it's a time to resolve conflicts from your life that have been unresolved, to reflect on joys, to make new joys like we did in my family, to make the most of the time that's left. And the comfort in discussing the end of life. Talking where there's a focus on the quality of life and memories from life, telling somebody what the person has meant to you, how they've influenced your life. There's a lot of deep personal connection that happens. The systemic lack of cultural awareness that we've talked about today is at every level, ethnicity, faith-based, family, individual levels. And to navigate all of those without some really good preparation is not really going to happen. And from the physician perspective as well, they can be generally aware of costs, but end-of-life care costs, when presented with split-second decision-making, is not top of mind, and there's not going to be a stop for a discussion about that. So preparing families in advance for what the types of costs are going to be relative to the types of care that they may choose is important. And again, fears and values. Physicians are not in tuned to patient fears and the fact that they make decisions based on those fears. Next slide. So an ideal process, I'm saying achieving the ideal process, is partially about public messaging that enables shared decision-making before a crisis. So education within the system, public messaging to help end the end-of-life taboo, making planning a natural part of life, educating other trusted advisors, getting a pulse in the medical record, and educating about all the things that I've just discussed, right up to asking people who will be caring for you, who will you be caring for, and in an emergency, what's the first step you'll take? Next slide. I'd like to talk about developing a rest of life plan, which is essentially what we did when my dad was approaching the end of life. And there are all kinds of things listed here that I won't read off to you in the interest of time that you can do to really make the quality of life much richer and deeper. And for us, at the end, it was really only one focus: is Dad in pain today? And it's a very different way to exist. But it was perfectly appropriate and wonderful for my dad. Next slide. And here are some action items for systems and for the public, a lot around education, a physician checklist for end-of-life discussions, a patient and family checklist, and when a physician verbally refers people to information, it's much more impactful than just having information in a packet that you get at the hospital. So I think that's very important. And again, the public information to educate people about all of the different options and what they entail. Next slide. And here we have the ethics principles, and I've seen some people add fidelity as a fifth principle, which I wholeheartedly endorse. And I will let you kind of take a look through this, but essentially it's a little bit of a slice and dice of what I've talked about previously, bucketed into the way it supports autonomy and beneficence and non-maleficence and justice and fidelity. And I think the biggest gift that we can give to families is a clear and realistic picture of what may come, what is likely to come, what the consequences are of different actions, different inactions, and really driving home that there's care that's likely to be futile, but there's great care that's available to keep somebody comfortable. And I will wrap it up with that thought. Thank you very much.
Yeah, thank you very much, Beth. We now have some time for some questions and answers, which we'll open up. I mean, I do think that, from the speakers, you realize that to really do this correctly, the physician and others need time. They themselves need to be organized, and they need a plan, as you saw, to give to the patient and to the family, because without it, it's kind of not going to be very helpful or useful. Are there any open questions? If not, a couple of them came to me. So I'll start with one of them, which is, how explicit should advance directives be? So when my mother was in assisted living, they gave her a form which said, sign yes or no DNR, and there were 4 lines for her advance directives. I mean, it was like, it was not enough space to even get started. And it took about 4 months to go through with my mother. It's not just DNR, do not resuscitate. It's, is it full comfort care only? Is it do not intubate? Is it do not defibrillate? If you get into a hospital, is it do not transfer more than once? Is it do not draw blood? Is it do not intravenous? This took a while, And physicians need to have that organized mind to help their patients through this. I at least was able to help my mother through this. So the advance directive needs to be as explicit as you can make it. So that when you're ill, or your loved one is ill, you have some idea of where to go. But I'll open this up if there are any other open questions. Yes. I don't see a name there. It just says iPad and your
Yeah.
yes.
I'm Joel Potash, class of 62. And I had the good fortune in the end of my career to be a hospice medical director and to achieve a board in palliative care. So my question is about education, because my experience as a hospice doctor was that I sat around a table with people of equal competence, a nurse, a social worker, a volunteer, and a chaplain. And I would go to somebody and they would say to me, I don't understand. I've been a good person. I go to church all the time. Why is God doing this to me? And I could find someone to help them with that. And the chaplain would go in and want to talk about that. And they say, I can't, I'd love to talk to you, but I'm in terrible pain. And I just can't do it. And the chaplain would say, I've got a person for you. So that experience of saying, I can't do everything. There are other people who do things wonderfully, and they are my partners. Are we incorporating that into medical education? Are we sitting in classes with social work students, nursing students, and chaplaincy students? And are we befriending them? And are we learning from them? So that's my question about education. But before I go, Brandon, I hope you do a lot of writing because you're terrific. So keep it up.
Anyway, Dr. Carver, I saw you shaking your head up and down. Would you like to answer the question, please?
I think it takes a village, as they say, and part of the doctor's story is very indicative of the importance of competence and professionalism from a variety of aspects, for sure, for quality end of life care. I will say that it has been encouraging, over the last 20 years or so. Certainly, I see it here at Cornell, and I believe it exists at BU, among other places. And there has been a greater focus than I would say, honestly, ever before in these issues. When we started giving talks, for example, from my world at the American Academy of Neurology, in 2000, you give a talk on end of life care, and there were 8 people in the room, and 5 of the 8 were the speakers. Now you could have 150 in the room, 200 in the room, and there's more of an interest among residents and fellows. I mean, in entering this field than I think ever before. So we got a long way to go, but it is encouraging. We do a lot of work in communication here. And we use local actors, and we pair them with med students and fellows. I mean, it's incredibly, it's great stuff, and it's also very encouraging to see people at the beginning of their careers, grappling with some of these issues that everyone has brought up tonight, that I think are very, are very potent and it's quite encouraging.
Thank you. Other questions? Yes. Ron? Yep. Oh. Yeah, Ron, you're muted. Thank you.
Ron Raglovan, class of 82, BU. Tremendously impressed by the thoughtfulness of each of the speakers. And I wanted to ask if some things might not be penetrated, understood, framed in an intellectual framework, is it appropriate for physicians to have a sort of existential love of people and patients and people that happen to be patients? Is that sort of existential love appropriate?
Somebody, one of the speakers want to answer that? Professor Rambo?
I was going to call him Brandon. I mean, I think, the word I use for theology is meaning making or existential meaning making. And I think there are gaps. Brandon could probably testify. In theological schools, theology can lose that very human dimension, which is strange, right? So there's some training problems between theological schools that train chaplains, clinical pastoral education, CPE programs in hospitals. Like there's not coordination, I think, in terms of the training. So interestingly, you're asking about doctors and existential training. Sometimes the students that I see in theological school are so framed by a very specific way of thinking about theology that it actually takes work to open up to the existential questions. That seems very strange to me. So when we're sending people into the hospitals as chaplains, I'm concerned about how we're training them in the tradition specific schools. I think Brandon's done some amazing work to try to get work done in maybe Brandon, you can talk about the group, but I think I'm trying to reframe theology as existential meaning making work that gives a nice bridge between the rabbinical schools and the Christian seminaries, and the work is existential meaning making. We're trying to train people for that. These are big themes of life and death. They're big themes of suffering and healing. So I'm just admitting, I think, some of the challenges that exist at the different for me, it's the theological school. I'm convicted. Are we training people to do this well? I think we have amazing graduates who are on this Zoom who do this well, but I'm not convinced that they get that from their theological training. And I think Brandon has a set of concerns about whether or not the medical professionals are trained to do that. So, Ron, this is an issue. I'm just saying, from my perspective, I'm working hard at it, but a lot of my colleagues, it takes a while. It's like, no, we're training people in tradition specific ministry. I'm like, no, not. We're training people in existential meaning making. Brandon, that was it. That was an invitation, Brandon.
Yeah, I think my peer and I at BU, we started the student group Grace, that's grieving, reflecting, and empathy, and we would just talk about death. And students had such a strong desire to be in that environment and to be among each other and to be having very raw and honest conversations around personal loss and loss that we saw in the clinic. And I think getting to that existential love that you were talking about, there are so many things that we can adopt that create barriers and distance. And I think in some insidious ways, they can be some of the most helpful frameworks, like theologies and philosophies and algorithmic frameworks and flowcharts and even ethical systems that can be useful or can be a way to create distance from the patient and distance from the vulnerabilities inherent to an ethical love, to an existential love.
Maureen,
Oh, hi, I'm Maureen Sims. I'm class of 72 from BU, then came out to California. And it's interesting because I saw at 5:30 tonight, I have a bioethics meeting with the Southern California Bioethics Consortium. And the topic is end of life options. And so they sent a whole series of slides, and we're going to talk about that because there's members in the group that are on both ends of the spectrum. And I'm not talking about diseases, I'm talking about how they look at it in terms of being very adamant against having that and thinking Canada is in another planet with what they're doing and thinking that they, go there. And then many of us on the other end of the spectrum that say, we should have their autonomy. We put it down clearly if we lose our capacity, what we want, and so forth and so on. Anyway, I took an elective when I was at Boston University and Vanderbilt in the pulmonary service. And there was a farmer who was 94 years old on a ventilator with obstructive lung disease. And he made it clear he wanted to go and please let him die. And his relatives all agreed. And so the chief of the service, the residents, the fellows, and me as a third-year medical student, we went in and held his hand, and he got a big dose of morphine, and he died. And I thought that was the way it was done. I thought that was my education on ethics. And then, surprise, not at all. As I became a neonatologist, I had that similar view. If some baby is damaged and very sick and not going to survive, and the family came to terms and all the nurses and the faculty agreed, let the baby go, I used that as my role model there and became very involved in bioethics as chair of a couple of committees. So I'm wondering, what's the temperature out there in Boston in terms of end of life options and so forth? I'm just curious. I'm going to share that with my colleagues at 5:30 when I talk with them and say, hey, this is the first time I ever went on a Boston University Zoom, and to hear all these wonderful speakers. I really loved it. Thank you very much. I'm going to continue to do this, but can anybody tell me which way the wind is blowing out there in Boston?
Well, I just say, well, Alan and I are in New York. But I
Okay.
will tell you that BU always has had sensitivity. I remember in social medicine back when I graduated in 1980, one of the books we read was by Victor Fuchs on who shall live. And so we've been at the med students at BU, even though Brandon may think that it's been inefficient, or incomplete, have always there's always been that view to discuss this and to elevate our sensitivities. I think that's been one of the rewards of Boston City Hospital, Boston Medical Center, is that we do see lots of patients with different diseases. So I'm just going to say at BU, I think that we do elevate the interest. I think we have to at some point complete our evening. If there are other questions, please send it on the chat to us. We'll gladly have one of the speakers come back and chat with you. I'll just say, having dealt with cancer in the past, remind people, tell a patient they have cancer, it's like slapping them in the face. And I tell that to my residents. They look at me like, well, just telling them matter of factly. No, it's like slapping them in the face. And ultimately, you need to do something. I think Brandon had that perfect example of what I call run and gun. As a surgeon, you have no time. You run in and tell the patient, you have this disease, I'll see you later. I think Brandon was absolutely correct. You need to be sympathetic. We don't have time to chat about it. It would have been better to say, hey, we have your path report back. It wasn't very good. We're going to come back at 11 o'clock this morning and sit down and chat with you. Give them a chance to kind of catch their breath. But to slap them in the face with cancer, particularly pancreatic cancer, and leave, you would not do that to anybody. And you should not do that to your patients. These are people that you should have some affection for and some sympathy for. So we brought up lots of different subjects tonight. I was very happy we included Professor Rambo, that I do believe. I see Sam Lowe is on here, another chaplain, that the chaplains play an extremely key role, just as social workers and others. I had to limit who we included in tonight's conversation, but hopefully you understand that we at the Chobanian Avedisian School of Medicine do have some sympathy for this, and that this is a subject we need to continue. As we expand our knowledge on how to treat cancer, we also unfortunately expand the options that we need to discuss with patients and their families, understanding, as we heard, that culturally a lot of patients don't hear anything we're telling them, and you need to have some sympathy as to how they're going to receive the choices that we give them. Again, there's my non-medical email. Please send me any subjects for future lectures. And obviously, the med school would love your donations. The lectureship does need your donations so we can continue doing this. And I applaud and thank all of you for participating. Please send me any other questions and we will continue to answer them. So to our speakers, Alan, Shelly, Brandon, and Beth, thank you very much. I hope to hear and continue our conversations. So thank you.